Thank you so much, sir. First of all, thank you for including me in your IC, and it's really a privilege and an honor for me. So, friends, whenever we see something like this in our OPD, the first thing that we need to remember is how are we going to manage this and what are we going to keep ready in the OR whenever we take up these patients for a surgical treatment. So, in order to know that, we all should know right from the basics that a CTR is something which is so important, whether it's an on table sudden problem which can cause a zonular dialysis, or a use in such patients where electively you have decided to use a CTR. It's basically where you want to stabilize the capsular bag and give the patient a best visual outcome. So, which size should be used? Also, we know that it comes in different sizes, and you check the wide to wide diameter and the axial length of the eye, and use these uh, CTRs. So, the basic principle is that there is a centrifugal force and an equalization of the distribution of the forces, so that you make the posterior capsule taut and stabilize the area wherever there is zonular weakening. It minimizes the fibrosis and contraction of the capsular bag also. So, what are the indications? So, first, when you have a localized zonular dehiscence of say less than 4 clock hours, whether it's due to trauma or iatrogenic, then you can use a CTR. So, important to remember is you need to have a perfect CCC. There should be no anterior capsular tears or a posterior capsular PCR also. So, intraoperatively, you first assess the extent of the subluxation, look at whether what is the number of clock hours that you have the dialysis or the zonular dehiscence. Check whether there is any vitreous prolapse. If that is there, then you need to first do an anterior vitrectomy and then only go ahead. And then, even during the CCC, you can actually see whether there's an anterior capsular wrinkling or the entire phacodonesis. So, these are the various. So, this was a patient where, when I was doing a CCC itself, you can see that there was a phacodonesis, and I knew that this patient has a mild to moderate generalized zonular weakness. There was no subluxation as such, but I went ahead and very, very carefully doing the nucleus management. But when we were doing the irrigation aspiration, we could make out that in one side, I could see the zonular bag which was getting weakened, and there was the edge that could be seen. So we stopped there, put in viscoelastic, and put in the CTR. And now, since we had stabilized the bag, it became much more easier, and we knew that we would not at least increase the zonular dehiscence. Otherwise, it could have caused greater zonular dehiscence, and the entire bag could have come out. So at that point of time, you need to take that decision at when to put in the CTR, and the next step of the surgery becomes much safer, and you can go ahead and complete each step of the surgery very, very easily. So, important if you are doing a subluxated cataract, where to take the incision. So, the planning has to be perfect. So, ideally, it should be at least 90 degrees away. Keep the section watertight. Even the capsular axis, the starting of the CCC also should be away from the area of the zonular dialysis. A very gentle hydrodissection, low flow, low vacuum settings. There is a important statement that you need to put a CTR as early as required, but as late as possible. So, for example, if you are putting it even before the phaco, putting in the CTR also is going to be very, very difficult. Managing the nucleus is going to be difficult. So many times you can put in visco underneath the CCC even before you are putting in doing the phaco, so that you create space and then you put in the CTR. So this was a patient where there was a traumatic subluxated cataract, and we decided to go ahead and use the flax in this patient. So use of flax in subluxated cataracts gives you an added advantage, because you can not only have a perfect circular capsulotomy, but also it can you can actually position it depending on where exactly the subluxation is, how severe it is, and you can go ahead and do a perfect technique. So this was the capsulotomy, and you can see that there is a large subluxation there, almost 3 to 4 clock hours. And once you've removed the capsulotomy flap, we are using capsular hooks, and that is giving us the vertical stabilization of the capsular bag. And then it becomes easy. You go ahead, and each of those already pre-cut nuclear fragments can be easily removed. Now, before I go in for the IA, I'm putting in the CTR. Always while putting in the CTR, you have to see to it that you're stabilizing it with the second instrument and ensure that the last part of the CTR is going in into the capsular bag. It should not slip in into the sulcus, because once that happens, then it can cause an anterior capsular tear, and you need it very difficult to go back and retrieve. Although one case had happened where then I used the bimanual technique and we retrieved the lost CTR. So once the IOL is in place, you can also remove the capsular hooks and the case is done. So this was the post-op picture. Contraindications is if there is a large anterior capsular tear or PC tear or a large Argentinian flag sign like this with a zonular dialysis, I think that becomes the most complicated way how you can manage it. So when you're using MCTR, that is the modified Sionis ring. So this was a patient, it was a 11-year-old child, and look at the astigmatism here. It's almost a 11 and a half diopter cylinder, grossly subluxated lens with a PSC cataract. How would you approach it? So easiest way would have been probably doing a lensectomy, vitrectomy, and then putting in either an SFIOL or an iris claw. But here you can also see the astigmatism on IOL master was just 1.77. So that 11 and a half diopter astigmatism was basically lens induced, not a corneal astigmatism. So this was how we managed it. The two side ports and then two more side ports for the capsular hooks. Now in this case, the capsulotomy is extremely important because you have to have a perfect capsular axis, and these are pediatric eyes, so they're more elastic, so very very high risk that it could tear off in the periphery. So we put in the capsular hooks, did a very gentle hydrodissection, and it's basically no hard nucleus at all. It's basically lens aspiration with the bimanual IA. And now we are putting in the Sionis ring. So here you have the Sionis, the hook. You put in the 90 or a 10-0 proline, and then now we are putting in the Sionis into the capsular bag and rotating it so that the eyelet comes into the area of the maximum subluxation. This was the partial thickness triangular flap. You can also use a Hoffman's pocket, and then you put in a bent 26 gauge needle underneath the scleral flap, and then railroad the straight needle of the 90 proline through it, and then do it again, and you get both these sutures out, and now you can tighten it, titrate it, so that you have the knot underneath the partial thickness scleral flap, and you can see that the capsular bag has been flattened there, and on the sclera you are just tightening it. So now you have a good capsular bag which is stabilized with this, and then you can go ahead and put in the IOL. So this was the final picture. Post-operatively, vision was 618 because of amblyopia, but the lens was sitting well. So the advantage here is that this does not compromise the integrity of the capsular bag, but remember that the eyelet comes on top of the anterior of the capsule, not underneath it. If you were to use a CTS, you could also have used a CTS with a CTR here, and that makes it easier because CTS is very small. It has a 120-degree arc and just a 5 mm radius. So you can use the CTS instead of using a modified CTR, that is the Sionis. And it can also be used, suppose that place has, you have an anterior capsular tear 90 degrees away, you can still put the CTS in that area. So this was where we used a Hoffman's pocket and used the CTS with a similar technique as we did with the Sionis. And the CTS can easily help to stabilize the zonular dehiscence in that area. So again, railroading with the 90 proline and then use of the CTS. So you put the suture before putting in the CTS inside the eye, and then it works well. So to summarize the function of the CTR, so we have, it's a lot underestimated. All the subluxated cataracts you have to plan very well, keep them in your armamentarium. If you have a zonular dialysis on table, CTR is something that will bail you out to reduce the risk of intraoperative complications and post-operative capsular contractions. Thank you so much for your kind attention. Thank you.